throughout my training and after my training, I found that this is one of the topics that many trainees and non-neuroradiologists usually struggle with. And it does cause a lot of stress because people are taught that intracranial vascular malformations can end up with bleeding. And so many times when people read cases, when they're not sure about whether or not they deal with a vascular malformation, they kind of basically get very scared, or they kind of don't really do a proper job in sort of classifying. And hopefully we can demystify this topic by the end of this hour and give you guys multiple chances to participate in the management of these cases. So no disclosures for this particular case. Here's the outline of my talk. We are going to be talking about the ISSVA classification of vascular anomalies, just to introduce that group that broadly classifies these lesions. Then we're going to delve into the intracranial vascular malformations, which are really only 5 types of lesions. And then towards the end, we'll talk about case examples. So again, I will highly encourage people to participate by doing the chat function. I see somebody's already drawing on my screen. So I will just refresh by stop share, and then I'll share again, and that will help to kind of get rid of that actual little thing that can be somewhat distracting for people. Okay, good. So again, can we just test, so I know that I'm not talking to myself? Can people just say hello in the chat? Maybe say where you are in Nigeria, so we just know that I'm not just talking to myself here on the screen, please. You guys are from Lagos. Where you guys from? Abuja? You know, let's get a little bit interactive. Not so make this very, very boring just listening to me. Right, Rwanda, Germany, right, Adamawa, right, excellent, that's awesome. Tanzania there, hello doctor, that's awesome, right? So Ibadan, that's great. Nairobi, that's awesome. It's really fantastic. That's great. That's great. The great news is you have these patients wherever you are. So hopefully we will help you to manage these cases. All right, excellent. Very good. You guys kind of get the gist of it. So ISSVA. So what is ISSVA? ISSVA is the International Society for the Study of Vascular Anomalies, okay? And this is a group of people who've taken it upon themselves to classify, identify, and classify vascular anomalies throughout the human body, everywhere in the human body. So it's an extensive classification system, and they've taken upon themselves to do this task. And by the way, this classification is available to you online on this link here, issva.org classification. And the last time they actually sort of solidified this classification was 2018. And every about 5 or 10 years or so, they go back again and they update the classifications. The most recent one that they have is from 2018. And I believe in 2026 or so, they're going to be revisiting this classification. So 1, remember we're talking about vascular anomalies, okay? Not vascular malformations, not vascular tumors. So vascular anomalies encompasses both. Why do I say that? Because the major branch point for these vascular anomalies is vascular tumors versus vascular malformations, right? And this is a very important concept because anytime you hear about a vascular lesion, you want to have a sense of, are you dealing with a vascular tumor or are you dealing with a vascular malformation? Why is that important? So back in 1982, right? This is almost like 40 plus years ago, okay? More than 40 years ago. These two authors, Mulliken and Glowacki, came up with this very important paper that is a seminal paper and has stood the test of time. So basically, whenever you find something that sort of stood the test of time for 40 years, that means it's probably the truth, right? So basically, they branched out the vascular anomalies into vascular tumors versus vascular malformations. So vascular tumors have endothelial hyperproliferation, whereas vascular malformations are more dysplastic vessels, and the key feature is they do not have endothelial hyperproliferation. It's a very important sort of distinction, and we are only going to be dealing with this category. So we're not going to be talking about anything that has hyperproliferation, including those that happen in the head and neck. Often you have orbital hemangiomas, facial hemangiomas, and those are growing tumors and so forth. That's not really what we're going to focus on today. Today, we are only talking about vascular malformation. So again, the broader category is vascular anomalies, and then it branches out into vascular tumors versus vascular malformations. Now, when you click into ISSVA classification, very quickly, the first part of it, you're gonna basically branch out again. You got vascular anomalies, that goes to vascular tumors or vascular malformations. We're not talking about vascular tumors, and we're not talking about the combined or complex. We're only going to be talking about simple vascular malformations, and these are about 5 of them. The great news is that we don't have lymphatic malformations in the brain, right? Because basically the brain doesn't really have a lymphatic system per se, right? So we don't really have lymph draining within the brain per se. So really we're dealing with capillary, venous, or arteriovenous malformations or arteriovenous fistula. So really, is it a capillary malformation? Is it a venous malformation? Or is it a shunt lesion that is combining the artery and the vein, meaning it's a shunt lesion? So that hopefully should begin to simplify your approach to these vascular malformations. Now, why do these guys bother and get super excited about that? Why are they spending all this time with these classifications? When you move forward, the hope is that as we better characterize, so one, we classify and put it into a bucket. So now we're talking venous malformations. When you go from venous malformations, you're going to get into cerebral cavernous malformations or cavernomas, which we'll talk about. You can begin to do genetic analysis of those particular lesions, right? And the hope is that as we have a better understanding of these vascular anomalies, we'll be able to better counsel our patients and hopefully provide different therapies for these particular patients. Just as in brain tumors, there is a move towards molecular and genetic diagnosis of diseases. So right now, most of the diseases we're just doing descriptive histopathological description of diseases. But now overall and all across, we're moving towards molecular and genetic description of diseases. So how can you get to molecular and genetic description when we can't even agree on the sort of morphological, phenotypical description of lesions? So that's really the hope, is at some point, by knowing that what kind of lesion are we dealing with and what underlying genetic or molecular basis does that lesion have, that can provide different treatment mechanisms. So that's really the crux of it. Obviously, we're not going to be doing genetic and molecular evaluations in the clinic, but that's where the future is headed. So that is the overall big picture. And then now we're narrowing down into the intracranial compartment where we're only dealing with vascular malformation. And the great news about this is we're only dealing with 5 lesions. So if you look at your hand, hopefully you have 5 fingers. So we only have 5 lesions. So anytime you're talking about an intracranial vascular malformation, the universe of lesions for you to consider is 5. And of those 5 lesions, 2 of them are shunting, 3 of them are non-shunting. Okay, and that's how they're divided, right? So the top 3 are non-shunting vascular malformations. The bottom 2 are shunting vascular malformations. Really, if I'm going to stop right here in this talk and you are able to sort of understand this, and hopefully this kind of lowers your blood pressure, that would be a very great place to stop. And this is, we're going to basically spend the bulk of the rest of the time talking about these vascular malformations and how they differ. So job number 1 is to understand that you are potentially dealing with a vascular malformation. If you cross that threshold, then you have to identify which type of vascular malformation are you dealing with, and it's going to be one of these 5. So in a multiple choice that we're going to be spending a lot of time this hour doing, these are the answers. At any given time, the answer is going to be one of these 5 lesions. So, if even if you fall asleep, basically have a 20% chance of getting the answer right. So just rest assured. All right, so let's jump right into it. So we're going to start with the cerebral cavernous malformation. So this one is an extremely common lesion. It has many, many names. I don't know what they call it in your particular practice. They call it cavernous venous malformation, cavernous malformation. Here in the US, cavernoma is probably the most common way that we kind of talk about it, and that's what the clinical colleagues expect us to say. But in red, I've identified terms that we should not use. Cavernous hemangioma, cavernous venous hemangioma. Those terms should not be used because hemangioma implies endothelial proliferation, implies that you're dealing with a vascular tumor. Remember, we are not dealing with vascular tumor. So this is not a tumor. It does not have endothelial proliferation. So preferred terms would be cavernous venous malformation, cerebral cavernous malformation. I personally use cavernous venous malformation. In parentheses, I say cavernoma to allow our clinicians to know exactly what we're talking about, and they're very, very familiar with the term cavernoma. So what are these things? These are hemorrhage-filled venous type vessels without normal intervening vein. Sometimes I say this is a vein trapped in the middle of nowhere. People will say these are immature blood vessels. They're called venous lakes. There's other ways to kind of think about it from a histopathological basis. On MRI, they're popcorn-like. They have a dark T2 hemosiderin rim. It has mixed internal signal depending on the stage of blood products. So you may have acute blood products, subacute blood products, late subacute blood products. So basically on T1 and T2, it tends to have a heterogeneous sort of appearance centrally because you have basically mixed stage of the blood products. And they tend to be associated with developmental venous anomalies, and they can run in families. Here in the United States, they're associated with young Hispanic patients, especially those who have multiple cavernous, cerebral cavernous malformations because it has a founder's mutation. Again, going back to the genetic basis, certain patients who have a certain sort of genotype heritage tend to have these multiple cerebral cavernous malformations. So how do they actually look like? So here's a case, illustrative case. Here's an axial CT image, and what we're seeing here, you can see this hyperdense lesion in the left anterior frontal lobe. We have the associated calcification. Initially, people may think, oh, how are you sure this is not a meningioma? So we're going to show you on a coronal and an axial to show you that really this is an intraaxial lesion. Now, anytime you have a asymmetric lesion with calcification in the brain, definitely a vascular malformation should be considered, although there are surface-based tumors such as oligodendroglioma, which also may show calcification on a CT. So we go ahead and we do MRI. So on MRI here with an axial T2, you can see that hemosiderin rim around it. On a FLAIR image, again, you see the hemosiderin rim with some heterogeneous products internally. Again, hyperintense on T1 pre, and maybe a little bit of contrast on the post-contrast image. And when you go ahead and you do a susceptibility weighted image, this is an SWI image, and here is a B0 image from a diffusion weighted scan. You can see that the lesion has a lot of like internal susceptibility signal, and that is a classic cavernous malformation. That's how they appear. Again, they're extremely common. Here's a nice one on another patient where you see it here in the right basal ganglia, this sort of hyperdensity. Remember, basal ganglia calcifications tend to be symmetric and they tend to be in older patients. So when you kind of see this sort of like subtle asymmetric calcification, please think, is there potential that you're dealing with an underlying vascular malformation? So we go ahead and we do MRI, and again, you see that hemosiderin rim with a bright central signal here on a T2 and also on a FLAIR. And again, on the susceptibility weighted, one we have on a diffusion and on the B0 just to show they have corresponding susceptibility artifacts. Again, cavernomas, once you sort of suspect it, they're very easy to kind of basically confirm whether or not you're dealing with a cavernoma. And really the crux of the matter is typical on a T2 weighted image. Do you have a dark hemosiderin rim with a central bright depending on the blood products of that particular cavernoma? And the question is always, do these show any enhancement? And basically, yes, they usually have faint enhancement. The reason you have the hemosiderin rim is basically the blood degradation products. And the idea is basically also, it is thought to have some like internal inflammation, and that's usually what causes like internal bleeding. So when these lesions enlarge, they're not enlarging because of endothelial proliferation, they're enlarging because of like internal hemorrhage. And we're not really 100% sure what causes the internal hemorrhage. And so as you hemorrhage into it, remember these are a venous lake, they're not really connected out. So when the blood hemorrhages into it, it's just gonna get degraded like anywhere else, but it's contained. So eventually that's why you get those hemorrhagic, basically hemosiderin rim. So the hemosiderin rim is really probably the key for diagnosis these cavernous venous malformations. So the twin, or one lesion that's often associated with the cavernous cerebral cavernous malformation, is a developmental venous anomaly. So usually the teaching is, if you see a developmental venous anomaly, aka DVA, you should look for a cerebral cavernous malformation, and vice versa. You basically, they kind of go hand in hand. So we like to talk about them together. So what is a developmental venous anomaly? This is arrested development of medullary veins. I think I would really say it's arrested branching of medullary veins. So basically what happens is these medullary veins all converge into one dominant vein that then drains the normal brain tissue. It has been called Medusa head, so that these stellate vessels, again, the medullary veins, they're sort of converging onto that draining vein. 20% associated with cerebral cavernous malformation. There is debate whether they can bleed or not. I would say I've seen very, very large developmental venous anomalies, and people have felt that if those thrombose, then they can be at risk of adjacent parenchymal hemorrhage. But it's extremely rare. And by the way, about 10% of MRI brains with contrast probably have a developmental venous anomaly. And so if you are reading MRI brain with contrast, let's say from a 1.5 Tesla scan, you should be probably calling a small developmental venous anomaly in about 1 in 10 MRI brains. It's extremely, extremely common. And the important thing to identify is when previously they used to resect cerebral cavernous malformations, you had to identify the adjacent developmental venous anomaly because it's draining normal brain tissue. If you resect or occlude that developmental venous anomaly, then you're going to basically cause a venous infarct. So we don't want to accidentally resect a developmental venous anomaly. So how do they look like? So this will be the classic. So if you look at the frontal lobe, you look at the cerebellum, you look at the occipital lobe, you look at the parenchyma, you're going to see the stellate appearance of veins that converge into one dominant vein. And that dominant vein typically goes back up to the superior sagittal sinus, or sometimes it'll go back into the ependymal veins and so forth. So again, remember, these are normal veins. They're draining normal brain tissue. They're just all converging into one dominant vein. This is to say, even over here, we have medullary veins, but they're not converging into one dominant cortical vein, and so you don't really see that sort of appearance. So again, the idea is we don't want to resect this lesion because now you're going to basically deprive this brain here of normal venous drainage and basically cause a venous infarct. I should just finish by saying here that we have a capillary telangiectasia case, and this is very different from those two, and hopefully the pictures will show that. So again, as I'm discussing these cases, I'm hoping that you are getting a sense that they look very, very different. Hopefully you can see that a DVA is very different from a cerebral cavernous malformation, and hopefully I'll convince you that it's very different from a capillary telangiectasia. So what's a capillary telangiectasia? This is just a cluster of dilated capillaries with normal brain tissue in between. So just like a DVA, these are just abnormal dilated capillaries, but the capillaries are otherwise normal. There's no proliferation, there's no endothelial proliferation, there's not going to be tumors. We know these by classic location. Typically located in the midbrain, pons medulla. It's a typical brainstem lesion. It has faint enhancement, tiny blush, and usually you have a little bit of like dark signal and gradient echo susceptibility. It's usually barely visible in T2-weighted image. So this is the kind of lesion when you see on a scan, you're not even sure if it's a real lesion. When it causes a lot of problem for us is when we have patients who come to us with a history of melanoma and they're looking for metastatic disease in the brain, and now you have these lesions that have a little bit of susceptibility and a little bit of enhancement. Could that be a melanoma metastasis? That's usually the clinical scenario where it plays out. So this is how it plays out. So if you're scanning through your scans and you see this dark T2 signal, you're not even sure whether 100% should you call this, right? Is this real? Is this a little bit of artifact? I don't know. And then you look in gradient echo, clearly it is there, right? So clearly, no question, we're having some susceptibility artifact at the ventral portion of the right thalamus. And then we basically give contrast, and you can see a little bit like faint blush. See how it's not discrete? This is not something you can easily measure and say, oh, it's a 1.5 centimeter enhancing lesion at the right posterior thalamus. It has that sort of like blush type appearance on the scans on the post contrast, and that is how a capillary telangiectasia is. So typically, a basal ganglia lesion or a brainstem lesion is a classic location. And again, if it comes out in a clinical scenario where you're concerned whether you're dealing with a melanoma lesion, then basically we would have to repeat the imaging at 4 to 6 weeks just to see. Obviously, melanoma metastasis is going to grow, but capillary telangiectasia will remain stable. So again, a graded echo will help you confirm it, and that's how that sort of appears. So we just basically have covered the universe of non-shunting intracranial vascular malformation. Okay, and hopefully I've convinced you that a cerebral cavernous malformation looks very different from a developmental venous anomaly. It looks very different from a capillary telangiectasia. So the point of this talk is, if you can get to, I am looking at vascular malformation, and after that, you just have to drop it in one of these 5 buckets, you've done your work, right? As a neuroradiologist, you've really, really done your work. And because that now has taken them from the entire other differential diagnosis, whether this could be tumor, whether this could be like a sequela parasitic disease, and other things that can cause enhancement and susceptibility signal artifact. Now, we're going to finish off just by describing the shunt lesions, which is again arteriovenous malformation, AVM, or duro-arteriovenous fistula. And I should pause here because this is the big one. The reason vascular malformations cause a lot of trepidation for our trainees and often even attendings is this one. This is what clinicians feel. When you say intracranial vascular malformation, they hear arteriovenous malformation, the big bad one that's going to bleed, right? That's what they're really, really kind of worried about. So we want to be very careful that you're not using arteriovenous malformation willy-nilly when you're really describing, for example, a cerebral cavernous malformation. Or you're describing a DVA and you say, cannot exclude arteriovenous malformation. Those are 2 different, vastly different lesions that we're talking about. And hopefully we can convince you of that shortly. So this is what people are worried about. This is the big lesion that basically you have an artery that has no intervening capillary bed. So an artery goes to a vascular nidus and goes out to draining vein. So there are 3 cardinal features of an arteriovenous malformation. You need a dilated pipe feeding it, so a dilated feeding artery. You need the vascular nidus that is replacing the capillary bed, and you need a large pipe draining it, meaning a dilated draining vein. If you do not have these 3 features, you do not have an arteriovenous malformation, period. Okay, so before you conclude finding suspicious of arteriovenous malformation, ask yourself, do you have a dilated feeding artery? Do you have a vascular nidus? Do you have a dilated draining vein? If you don't have all 3 features, you do not have an arteriovenous malformation. Or you have a really tiny arteriovenous malformation, which really on cross-sectional imaging, you're not going to be able to diagnose. You will have to go to a diagnostic, a more invasive cerebral angiogram. Now, the classic one is typically a PO arteriovenous malformation, meaning the dilated feeding artery is typically from the so-called Willis, right? It's basically from the internal cerebral artery, or it's coming from the vertebral artery, but it's really supplied from the branches of the so-called Willis. However, you can have mixed PO and duro, meaning they're having internal ICA supply and also external supply. We'll talk about the grading of it, and again, this is a special mountain grade classification, which talks about size, location, and venous drainage. And this, again, has stood the test of time. This was described in the 80s, right? And has stood the test of time. They use this grading to decide whether or not these lesions are amenable to surgical resection. So based on size, location, and the type of venous drainage. Yes, they have a huge risk for hemorrhage. That hemorrhage is caused by aneurysma and basically weak angioarchitecture. So you can have an aneurysm from the feeding artery. Remember, it's a fast flowing blood, so that can cause a flow-related aneurysm. You can have an aneurysm within the vascular nidus, and you can have an aneurysm on the venous side, which is called a venous varix. So it has multiple points of weakness and failure, and that is why these lesions are extremely dangerous and tend to basically result in massive hemorrhages. And these patients, if not treated, basically do not survive. So this is why anytime somebody hears vascular malformation, they tend to be very worried, because they're worried that they may be missing this particular lesion that can then put the patient at risk for hemorrhage. So here is one of that example. Again, on a non-contrast, you want to be on your guard, right? So I love this case. If we're doing like in a test mode, we'll ask, why do you use this thing hyperdense? Some people, oh, maybe you have a hyperdense like gyrus or something. No, you can't have a hyperdense gyrus that's sort of like painting one gyrus, right? This is serpiginous, right? It looks like a little worm. It looks like a little snake, right? That should remind you that you're probably looking at a cortical vein, right? Anytime you're talking about something that looks worm-like or snake-like, that is the word you use, should be serpiginous. And as soon as I say serpiginous, that should trigger that, oh, I may be talking about a vascular lesion. And then on the parenchyma side, you have a little bit of hyperdensity, maybe calcification. Okay, calcification, that's pointed like a vascular lesion, right? What's the next step? You have to do a vascular study. That will be a CT angiogram or an MR angiogram or an MR with contrast. And when you do that, voila, it becomes very, very obvious that serpiginous thing was a giant draining vein going back to the superior sagittal sinus. And here we have a dilated feeding artery from the ACA that's basically supplying that, right? And then here you have that vascular nidus. Now we have a large draining vein, a large feeding artery, and a vascular nidus. Now we have all the three cardinal features for anterior venous malformation. So boom, you've done, right? 100%, you've like diagnosed it. You know, you don't need to go to angio. Basically, we know exactly what's going on with this patient. Now, to go one step further, we want to kind of give a sense of like, how dangerous is this thing? Can we actually intervene with this thing from a surgical basis? Can it go for resection? So that's when you come back with the Spetzler-Martin classification, right? So we're going to talk about the size of the nidus. So we're going to measure what is the maximal dimension of the nidus. How big is the nidus? Is it 0 to 3 centimeters, 3 to 6 centimeters, or greater than 6 centimeters? Okay. Is it draining superficial or deep? Is it going to the superior sagittal sinus, or is it coming down to the internal cerebral vein and then veno-galen? That's deep. That's going to be very difficult to resect. And then lastly, is it involving eloquent brain? Meaning, if we resect this part of the brain, is the patient going to notice? Well, this is probably involving the precentral gyrus area, right? This is probably posterior frontal lobe. So yes, they will become paralyzed. So we want to make sure that's not really what we leave our patient with in surgery. So that goes to Spetzler-Martin. So here's the grading system. They get 1 point for each one of those things. And that sum of the points basically gives you the Spetzler-Martin grade. So if it's less than 3, 1 point. 3 to 6 centimeters, 2 points. Greater than 6 centimeters, 3 points, right? Non-eloquent, 0 points. Eloquent, 1 point. If it's draining superficial only, that's 0 points. And deep veins is 1 point. So for our lesion, if we just kind of play around a little bit, right? So this thing is basically about 3 to 6 centimeters. So they get basically 2 points for that. Is involving eloquent cortex, they can have 1 more point for that. It's draining to the superficial, right? It's basically at 0 points. So this is a Spetzler-Martin grade 3, right? That's basically how you dictate, right? So patient has a Spetzler-Martin grade 3 arteriovenous malformation. It's supplied by feeders from the anterior cerebral artery and is draining towards the superior sagittal sinus, and it's located in the posterior frontal and parietal regions, likely involving the pre and post-central gyri. So that will give them a sense of like, what is the surgical risk should they attempt to resect that lesion. So that's the exercise that you want to do. Now, so short of you being able to do this exercise, your report should not really be sort of suggesting willy-nilly that we're dealing with an arteriovenous malformation. As you can clearly see, it does not look like a DVA. It does not look like a cerebral cavernous malformation. It certainly doesn't look like a capillary telangiectasia. So we want to basically reserve arteriovenous malformation for this exact kind of lesion. And that will really do our patients a lot of like favor in terms of help them move along the spectrum of management, right? You don't want to basically recommend AVM for what is otherwise a cerebral cavernous malformation and vice versa. So just to wrap this up, we should talk here about duro-arteriovenous fistula. This is probably the toughest one. So this one, if you don't diagnose this for several months at a time, you are forgiven. This is the toughest one for us to diagnose based on our conventional imaging alone. Typically, this is best diagnosed on our more invasive cerebral angiograms that are much better able to see this particular lesion. But we should think about it because this is another way in which we can have arteriovenous shunting. So this is where you have arterioles that are going directly to the venal to the wall of the dural venous sinus. Sometimes I usually explain this to our trainees as cavernous transformation of the portal vein. Okay, so it happens also elsewhere in the body. When you thrombose the portal vein, suddenly because of the hypoxia, because of the venous hypertension, arterioles are going to parasitize that thrombosed venous structure. So that's typically what happens in this particular case. So often when you have thrombosis of the sigmoid sinus, thrombosis of the transverse sinus, often that will also go concomitant with the dural AV fistula. It's not really clear what starts first, whether the sinus leads to thrombosis or trauma leads to the shunting, what happens, but basically the point is you often have them together. Whenever you have a dural AV fistula, often that particular sinus is often thrombosed. So clinically, these can be picked up in two scenarios that are reasonably common in our profession of neuroradiology. Pulsatile tinnitus. I hear ringing in my ear, and it's unilateral, right? And it goes for a long time, right? That basically can be an indication of pulsatile tinnitus because of that shunting is sending more blood towards the tympanic cavity. Another very common scenario is a cavernous carotid fistula, which has a direct and indirect. In the setting of trauma, especially with all of our proliferation of motorcycles and everything, even in Tanzania recently, we had a huge direct cavernous carotid fistula. That is a hole going from the carotid into the cavernous sinus. It's a huge hole, right? That is going to be acute onset, post-trauma, and patient's going to get massively dilated ophthalmic vein and usually present with proptosis, usually within a day or two after trauma. That is very different from a slow sort of proptosis, slow pain from an indirect. So the indirect cavernous carotid fistula is an otherwise dural AV fistula. So that's the sort of difference between the two. There are several classification systems. The two of them are Borden and Cognac classification. We're going to talk about them very briefly. Suffice it to say, the risk of hemorrhage from a dural AV fistula is related to whether or not there is corticovenous drainage. And corticovenous drainage just indicates that we have venous hypertension in the system, right? So when you see corticovenous drainage, that is indicating that we have venous hypertension, and that is what results in the risk of hemorrhage. And those hemorrhages are essentially venous hemorrhages because of that venous hypertension. So how does it look like? So again, as I said, these are much easier to diagnose on a catheter-based cerebral angiogram. So this is an AP view, anterior posterior view, where we're injecting the left occipital artery. You're injecting the left occipital artery, right? That's an external branch. And watch what's happening, right? All of this shagginess, right? All of this stuff, right? These are the little fistulas that are basically parasitizing into this transverse sinus, right? And you can see this is an arterial injection. We already have filling of a venous system, right? That is the shunting, right? When you're injecting in an arterial phase, we should not have like venous outflow, right? Because it first has to go into the capillary bed and then kind of come back out into the venous system. The fact that you're seeing it in the same point is showing you that basically we have arterial venous shunting. Not only that, when you wait a little bit, you see that this contrast is not dumping down, it's going anti-gravity, right? It should be dumping down into the sigmoid sinus and going to the IJ, except it's going back out in the cortical veins. So this is basically venous hypertension, cortical venous drainage. So this extensive cortical venous drainage, and this basically puts the patient at extreme risk for basically venous hemorrhagic influx from that venous hypertension. This is the same patient in a lateral projection. Again, the catheter is here lodged into that left occipital artery, and again, show you this shagginess. This little shagginess, that is the parasitization that is basically going into that sigmoid and transverse sinus. And when you wait a little bit, you can see here we have filling of the IJ on the contralateral side, but a lot of this is corticovenous drainage that is basically coming back up. So in the classification, Borden and Cognac, we spend a lot of time trying to decide whether or not there is cortical venous drainage. So I like simple classifications. I think basically when you move to more than 3 things, most people cannot keep track of it. So I like the Borden classification because it's very, very straightforward. And this article here, I highly, highly recommend it, Gandhi et al., like Mahatma Gandhi, but it's not really Mahatma Gandhi. Just to kind of make it easy for you as you're searching for it online. It's a 2012 paper. It's only 6 pages, but I think it probably does the best job of quickly describing dural AV fistula. So again, it's a confusing topic, but suffice it to say, the distinction is whether or not you have cortical venous drainage. CVD is cortical venous drainage, and basically, so type 1 is benign and has no cortical venous drainage. Type 2 and 3 are more aggressive, and both of them have cortical venous drainage. So highly recommend that. And really, when you go in, has these few figures here. Again, for our colleagues here, whenever you're reading radiology papers, just focus on the pictures. So this is the one place where if you just focus on the pictures and you understand the pictures, you pretty much understand the article. So let's try this, right? So here, again, like our case, right? You have the occipital artery is giving feeders. These feeders are basically going into the transverse sinus. Notice how this antegrade flow, right? And here's the vena lavae, but there's no flow into the vena lavae. So therefore, this is a type 1 benign Borden dural AV fistula. Now, in here, similar case, but now we have thrombosis or stenosis of that sigmoid sinus. And now the same dural AV fistula is resulting in retrograde flow. Not only is it going back up to the superior sagittal sinus, but now it's resulting in cortical venous drainage coming up to the vena lavae. So this is an indication of venous hypertension. And now this becomes an aggressive type 2 Borden dural AV fistula. Now, unfortunately, type 3 is not a continuation of type 1 or type 2. Type 3 is a different connection, right? So we are not connecting we're not connecting an artery to a dural venous sinus. We're connecting an artery directly to a cortical vein. So when you see here, abnormal artery, abnormal middle meningeal artery is sending feeders directly into a cortical vein. Right? It's sending directly into a cortical vein. It's not sending it to the superior sagittal sinus, right? There's vessel occlusion, I guess, between this cortical vein. So this connection between artery direct to the cortical vein is going to result in a Borden type. Remember that we now have direct access into the cortical, we're basically causing venous hypertension directly. It's not going first in the sinus and then refluxing back to the cortical vein. It's going directly into the cortical vein. So this is also an aggressive Borden type 3 dural AV fistula. Just quickly, Cognac classification talks about the same thing, but now adds all these other categories, which I think is probably beyond the scope of this particular talk that we have today, but I'll just point you to this so you're at least aware that there are other ways of classifying this. Your neurosurgical colleagues may be more interested in kind of getting into the nitty-gritty of all of this. Just remind them that it's really about cortical venous drainage. That's the only thing that matters. After that, we're kind of getting a little bit into minutia. In picture form, this is what that means. Basically, again, occipital artery to the sigmoid sinus. Again, anterograde flow, type 1, right? Again, even here, even though we have retrograde flow, it's still a type 2A, it's still, these are benign. The moment you start to have cortical venous drainage, now you're getting into the aggressive kinds. So again, you can have cortical venous drainage with going to the superior sagittal sinus, type 2B, type 2A and B, and kind of goes a little bit crazy. You can go where it has ectasia, it doesn't have ectasia, it was going down towards like the spine and so forth. But the point is whether or not you have cortical venous drainage, that is the key point. That's really the only thing that we need to give them from a diagnostic neuroradiology perspective. So again, this is just going back to our case. So you would ask yourself what kind of like Borden type dural AV fistula you're dealing with. So most likely here we're dealing with a type 2 Borden classification as we sort of described before. So that was a brief rundown of that. We tried to take you guys through a whirlwind tour of vascular anomalies. We also kind of described those 5 intracranial vascular malformations. So now for the last 15 minutes, it's going to be a fun part of this thing. So I hope you guys play along. And again, you have 20% chance, even if you're asleep, to basically get the right answer. So, relax and basically just play along, because really, as you engage in these cases, is really going to help you with your own diagnostic ability the next time you see one of these patients in your practice. So here are the answers, right? I wish I just put A, B, C, D, E, and you can basically just write A, B, C, D, E. But actually, I think it's even better when you start typing these particular words there, and that will help you with your vocabulary and make it easier for you to remember to use these phrases next time you encounter these lesions. So we're going to see a few lesions and see. All right. So again, let's just jump into a 59-year-old female with history of recurrent subarachnoid hemorrhage at the left temporal lobe, the temporal parietal region, reported outside hospital. OSH is outside hospital. So this is how it plays out. So this patient kept coming back like 3 to 6 months. Every time they come back, they go to this hospital, they say they have a little bit of subarachnoid hemorrhage at the left temporal parietal region. They come back, a little bit of hemorrhage at the left, right? So basically, how are you hemorrhaging subarachnoid at the same exact location like 4 or 5 times in a row? Now, if you look at it very closely, you will realize that this hyperdensity is not in the sulcus, right? So you got to pay attention a little bit, right? So we need a little bit unusual history. Like, why are they hemorrhaging at exactly the same point? And if you look at this sagittal, you will realize that this blood is not really in the sulcus, right? It may be a little bit subtle, but trust me, this blood is really gyriform. It's outlining the gyrus and not really, because you can see a little bit like sulcus right here. That's the first clue that likely this is not subarachnoid hemorrhage. Nevertheless, they go ahead and have MRI. So MRI helps us. Whoa, we see a hematocytic rim, and we have a little bit like bright central T2. What are you guys thinking? Let's get some guesses. What are we trying to describe here? Hematocytic rim, bright central T2. If everybody's awake, let's get some of the chat going here, so we see how people are doing. Right. So somebody says carcinoma. Right. Only one person is awake. All right. All right. So that's good. All right. So people warming up. All right. So you just get comfortable. It's okay. It's okay. It's a safe space. It's for us to make sure that we are issuing correct diagnosis. Excellent. So carcinoma. So carcinoma is the easy thing, or we can use cavernous venous malformation, right? So say cavernous venous. Somebody say carcinoma with DVA. Well, I haven't showed you a post-contrast image, so you cannot really see a DVA. So please don't assume that all cavernous venous malformations have a DVA, right? That is not 100% true. Okay. Now, so again, reduce susceptibility. You guys like knock this out of the park. All right, good. Cerebral cavernous malformation, 100%. You guys got it. Excellent. Now we have this case. What do you think about this case? Hematocytic rim, right? Left superior temporal gyrus, right central T2. What do you guys think? What do you guys think? Right? Are we describing the same thing? Right? Somebody jumped in, said carcinoma. Anybody else? Wow, man, we got like 100 people in this room, but only like 10 people are participating. Is everybody else asleep, or I don't know what time it is in Nigeria? Right? Let's play along so all of you guys get a sense that you have a chance to participate, because your patients will present with these lesions, right? The typical presentation is going to be seizures, right? So whenever patients have seizures and you have this kind of lesion, really, really think about a cavernous venous malformation. I show this a little bit unusual. Many times we describe it as a popcorn or mulberry appearance, as how other people describe it, but literally cerebral cavernous malformations can happen anywhere. So this is just another cute cerebral cavernous malformation at the left superior temporal gyrus. Excellent. So you guys got it. All right, good. All right, basically T2 and flare are complementary and basically show you exactly the same thing. Hematocytic rim with central bright T2 signal going there. Excellent. Now, this is another one. All right. So I'm not sure to show this case, right? So, right, patient comes in with a headache, right? And resident trainee, let's speed up on the resident trainee, discuss a little hyperdensity, maybe stipple calcification in the right frontal lobe here. And again, little bit like hyperdensity, right frontal lobe. But then I said, oh, I see something serpiginous. All right, I see something serpiginous. All right. All right, so okay, I am dealing with something vascular, right? So those are the clues, right? You are going to be reading, the vast majority of the cases you're going to be reading are going to be non-con head CT. And so your job is to move this patient from a non-contrast head CT to the next study they're going to do. So what we're going to do for this case, maybe we'll get a CTA. Voila, we get a CTA. You get a CTA, there's a large venous structure, right? With a stellate appearance at the edge, right? So what are you guys thinking here, right? Somebody jumps in AVM, right? Somebody jumps in AVM, stellate appearance, right? I did not say vasculinitis. I said stellate appearance. Look at the branching pattern, okay? AVM is exactly what the first person said. So big draining serpiginous AVM. No. AVM, we said it must have a vasculinitis. This is a branching pattern. Remember, a DVA is a branching abnormality. Normal veins, abnormal branching pattern. normal veins, abnormal branching pattern. So stellate appearance. So this, right? Go look up caput medusa, right? You have a tree with a branch and then many, many little branches, right? That is not what an AVM looks like. So do not get fooled just because you have this dilated big vessel. When we come down, all right, same case, right? What are we describing here? Hemosiderin rim, right central T2. What do you think? We have a DVA and DVA with what? DVA with what? Excellent. DVA with a carcinoma, right? So this is a situation whereby we have a twin lesion, right? And you can see this beautiful medullary appearance of those veins, right? So you see how it's kind of like nice little branches. An AVM is not going to have nice little branch. The moment you're saying branches, you're not describing a vasculonitis. A vasculonitis is an abnormal tangle of vessels. It's not abnormal branching of vessels. So anytime you have little branches, you're not describing an AVM. So that's the case, and here you can see, right? See, that's almost in a line, right? This is almost in a line draining into this big vein. So this is one of those trick cases where if you're moving really fast, you're gonna just jump, oh, there's a big vessel there, AVM, I'm done, AVM, all right? So slow down. This is a developmental venous anomaly with a cavernous venous.
Lollipop,
Okay, all right, sounds good. All right, good. So here's another one, right? So fourth, different case, right? Fourth nerve palsy, diplopia, most prominent on downward gaze. Rule out temporal right. So case came in, right? And it's a little bit more tricky, but I will point out that we have a vessel that's prominent over here. It's at the superior part of the orbit. So if it's a superior part of the orbit, I'm gonna call it a vein, superior ophthalmic vein. So this superior ophthalmic vein is 3 times the other one. What are we describing? What are we worried about? What are we worried about? Anytime you have dilation of the superior ophthalmic vein, what should we be worried about? That's your clue. That's your clue. We talked about CC fistula. Awesome. CC fistula, right? Cavernous carotid fistula. Indirect or direct, right? I'll tell you, there's no history of trauma. So what do we thinking here? Right? Is it gonna be direct or indirect? If there's no trauma, is it a direct CC fistula, indirect CC fistula? Indirect. Awesome. You guys are like, right? So how are you gonna see this, right? So you're looking on a regular cross-sectional imaging, you see abnormal tangle vessels, right? You see all these little vessels in the right cavernous sinus. That is your dural AV fistula, right? You see all these little abnormal vessels in there, which we do not see on the contralateral cavernous sinus. This is how a normal cavernous sinus should be, right? You have a cavernous segment of the ACA, and then just a pool of blood in the cavernous sinus. What is all these tangle of vessels, right? That is your dural AV fistula. So this was an indirect cavernous carotid fistula. It was a dural AV fistula on the left, right? And again, just to point out on our time of flight, this is a time of flight MRI angiogram. And what it's showing you, you should not see venous flow, right? You should not see venous structures on a time of flight MRI angiogram, right? So anytime you see arterialized flow, this arterialized flow within the cavernous sinus, right? That is an indication of a shunting lesion. And in this case, this was a dural AV fistula. The patient went on to an angiogram, and you can see in that injection, quick draining into that cavernous sinus. So this is all venous drainage, right? This is arterial branch. We haven't even got to the capillary phase. It's already draining back down into the IJ. So that is basically a dural AV fistula. They went on to basically completely embolize that. Sometimes they'll actually go trans through that dilated superior ophthalmic vein and basically drop in a lot of like embolization material, typically onyx blue, and that's how they treat these dural AV fistula. So the patient did really well. This is just pointing out, incidentally, what was picked up was a Borden type 1 dural AV fistula, again supplied by one of the external branches, and you can see the early venous drainage. So basically on these cerebral angiograms, we have a really great resolution, so we're able to see anytime we have like early draining veins, and again, this is a completely incidental finding. So that was a good example for a dural arteriovenous fistula. All right, good. How about this case, right? So patient comes in, huge hemorrhage, right? Huge hemorrhage, right? Parenchymal hemorrhage in the right temporal lobe. Okay, it has like intraventricular extension, right? But we're beginning to see there's some like little like tangle of vessels. Oh my, all right, it's a little tangle of vessels. So we like zoom in and we say, oh yeah, I do see a little like tangle of vessels. So what are we worried about here, right? Abnormal tangle of vessels next to a large parenchymal hematoma. What should we be worried about? Right, so somebody said it, right? So this is the bad actor, right? This is the bad actor, right? Now, this is what we're worried about. This is no longer cavernous venous malformation. This is no longer DVA. Remember, I wouldn't really raise a DVA if you have this like 10 centimeter hematoma within the right temporal lobe. So that is a that's an arteriovenous malformation. They go on to have an angiogram, and an angiogram is going to be super selective, and you can see a nidus, you can see a large draining vein, you can see a large feeding artery, right? Again, this is a tiny thing. This is probably like 1 centimeter AVM, but look at how big of a hematoma that thing caused, okay? So AVMs are bad actors. They're really, really bad actors. Why? Because these vascular niduses are not, they're very fragile, right? They're very fragile. So it doesn't have to be a big, right? When you have a big one, you're very lucky, but often they're small little things, but they can cause a lot of trouble, right? So this small little maybe like 1 centimeter thing cause a 10 centimeter hematoma that would easily kill that patient, okay? So they go on with a proper diagnosis. They go on and super selective. Again, we're trying to select that little like AVM. They go in with like a catheter, they're threaded. These are our interventional neuroradiology colleagues that basically feed and go into that feeding artery, and now they selected the nidus nicely. You can see a nice draining vein, and now they're in a position to glue that thing and completely occlude it, which is the next picture, and voila, that AVM has been treated. Without a nidus, would this be a dural AV fistula? Now, you cannot have a dural AV fistula that is basically going there. So that's an interesting question, right? So you would have to then have the one. Remember, this is a branch of the circle of Willis, and we don't really have connections directly from an artery to a vein in the parenchyma as a PO. As is strictly speaking, most of the time, dural AV fistulas, something maybe I didn't emphasize, they tend to be external carotid branches. They're dural branches, right? And that's usually why they're called dural arteriovenous fistula. That's to remind us most of the time the feeding artery is not within the circle of Willis. It's typically sort of dural based and so forth. So maybe that's one way to say. Yeah. So that would be it, right? What if you do not have an angio for this? So my point is this prominent cortical vein, right? So for a dural AV fistula, unless you're saying this is venous reflux, right? So that you would have to then say that the dural AV fistula is in the sinus, and then this is cortical venous drainage. But look how circumscribed this is. Usually when you have cortical venous drainage, there's a lot more like engorged, like, vein, because it's the whole system. The whole venous system is engorged. Your thought process is correct, but I think it's very important to understand that a dural AV fistula typically happens within the dural venous sinus. So you have to say that that culprit lesion is in the dural venous sinus. I think maybe that's one point. But I'll show you another case where we have a really prominent cortical venous drainage to kind of hammer home that particular point. So that was the bad one. That's the arteriovenous malformation. Here is that case. I'm just gonna do this as like show and tell, right? So you get this case. Oh my God, it's like super crazy. Like, what's going on? Why do we have all these squigglies? Why do I have all these serpiginous like vessels all over the place on T2? This is a proton density. We give him contrast. Oh my God, why are we having all these like, prominent structures? I love this case because one, the first question is, are you looking at arteries or veins? So let's play a game here. Who votes for arteries? Who votes for veins? All right, let's play a game, right? We got a few more minutes here. All right, guys, let's play along, man. We're almost to the end. What are you looking at? Are you looking at arteries? Are you looking at veins? Arteries, veins, arteries, veins. All right, 50-50, guys, 50-50. We can play this, right? We can play bet. We can play, right? Let's play. Arteries, veins, arteries, veins, arteries, veins. Let's get about 20 people. Capillary. I was already decided, I'm gonna go out of my way. I gave you the answer. Okay, if I'm teaching and I give you the two answers, you can't come up with your own answers. Whoever said capillary, you're not even playing along, man. Right? The choices are arteries or veins. The veins, these are veins, right? So this is a vein. It's a very important concept here. One, if you look closely, right, probably down here you're gonna be dealing with a carotid, right? Down here we're gonna be dealing with carotid. The point is the arteries always branch and get smaller away, right? The arteries always branch, right? You can't have a tree that's a huge mother trunk and then a branch that's bigger than the mother trunk. It's not gonna happen. Okay, so the artery always branches as you go distal. So the fact that out here distally we have vessels that are bigger than the MCA, automatically that tells you we're doing like veins. Okay, that is basically one quick way to kind of say, are you dealing with arteries or veins, right? So the veins can engorge, right? Because these are corticovenous drainage and that can engorge, but basically arteries always branch as they go distally. So this is one of those examples I was saying that we're dealing with like the extreme case of like venous hypertension. So that's basically, and then now probably they have a dural AV fistula on the contralateral side, though I don't really have images to 100% sort of confirm that. But this is a good case where you have like really engorgement, and is the point I was trying to make. When you have corticovenous drainage, is usually not one vein. There are many veins that are going to basically engorge because the whole venous system is dilated. So we're getting towards the end. I think I have like I think this may be the last case. Intraventricular hemorrhage over there, right? It's like next case, right? So not much. I mean, you really squint to kind of say like, you know, is there something here that maybe like some underlying lesion? I'm not 100% sure. Okay, all right, fine. We're gonna get a CTA on it, and voila, they have a prominent draining vein. We have little nidus, right? Little nidus. We have also have a little intranidal aneurysm, right? Remember, right? So this again, the lesion is not in the durovenous sinus. So what are we talking about here? What do you guys want to say? What caused the hemorrhage? Team, what do you guys want to say? What are you going to say? We don't know the source. We need to go to an angiogram like any, right? What are the choices? What are the choices, right? There's rupture. Rupture of what, right? AVM, right? Do you see the intranidal aneurysm? Intranidal aneurysm. Right? See that little dot? Here's the nidus, and then we have these like intranidal, right? So they go in on MR. You can see actually those little like, you know, intranidal aneurysms. It's kind of really cute. And then voila, on the angiogram, you can actually begin to see. So not necessarily, sorry, I misspoke. Not intranidal, but feeding artery aneurysms, right? So these are, sorry, the nidus is here, and then you have these other sort of like, you know, feeding arteries, so like, you know, aneurysms. So that was again a perinidal aneurysm, not in the nidus itself, but basically surrounding it, typically from the feeding artery. So the point here is you have the nidus, but look around. The feeding artery or the draining vein can also have aneurysms, and those can basically result in hemorrhage. So again, I was showing you that small AVMs can cause a lot of trouble, right? So that little AVM is what causes huge hemorrhage, right? So again, when you have huge hemorrhages, don't think necessarily you must have a ginormous AVM. Small AVMs can cause a lot of havoc because again, they are very fragile. The nidus is a fragile structure, right? Because these are really sort of like abnormal vessels. They're not really normal vessels that they tend to basically easily rupture, especially in the setting of hypertension. So I think this is the last case, just to show you that, you know, you can have more than one lesion. I'm going to do show and tell. Again, on T2, you can see the vascular nidus, left frontal region. We also see a vascular nidus on left posterior. And again, you can see this huge draining vein towards the superior sagittal sinus posteriorly, right? And again, on a time of flight, we can see arterialization of flow within the superior sagittal sinus. And again, that is a big clue that we have a shunt lesion. We should not see the superior sagittal sinus on an MR angiogram, right? So again, when you go in and you do an angiogram, just an early arterial, you can see a huge AVM posteriorly and a huge AVM anteriorly, an early draining vein, and so on. So again, just to show that, and this was actually mixed because they actually had both external supply. Remember how I told you can have a PO and dural arteriovenous malformation? This is showing you that basically we have it's parasitizing vessels into through the skull. So basically, you can have they go through the calvarium, transossets dural feeders, and they're feeding that giant AVM. You can see this huge occipital artery that's basically going to supply that AVM. So again, just a arteriovenous malformation that happens to have both PO and dural components. So today, we had the opportunity to kind of introduce you guys to the ISSVA classification, where we talked about vascular anomalies. We broke those up into like vascular tumors, and then vascular malformations, and then we talked about our five favorite intracranial vascular malformations. We shared a few examples, and hopefully after this talk, you have some confidence about distinguishing to those five intracranial vascular malformations. So thank you so much for your kind attention. I'm very pleased to have had a chance to connect with you guys and chat about this topic. You can reach out with any additional questions. But again, I just thank you so much for your kind attention.